Okay, good afternoon, everyone. You're all very welcome to this virtual session on ambulance IPC protocols and after transfer of a highly infectious patient. My name is Kwarikunda Charity, and I'll be moderating this session. And joining us today, we have a team of experts who are going to take us through this, and they will provide valuable insights into the best practices for protecting the patient and the EMF providers. So we shall have our experts introduce themselves, and I'll begin from my right. You're welcome. Please introduce yourself.
Thank you, moderator, for making this session. Good afternoon, everyone listening in. My name is Lewel Oteho, Regional EMS Leader for Kampala, and I will be sharing in this session. Thank you.
You're welcome. And how about Dr. Marion? You're welcome.
Good afternoon, colleagues. My name is Dr. Nakyeyune Marion. I'm a medical officer working with the Ministry of Health, EMS department. You're welcome, and thank you for being with us.
You're welcome, Dr. Mr. Andrew.
Good afternoon, everyone. Thank you for joining in. My name is Okiror Andrew, and I'm one of the presenters of today.
Okay, thank you so much, our experts, for sparing your time to come and share with us your knowledge and skills. And today's session will aim at reviewing and discussing steps of ambulance disinfection. We shall also discuss IPC controls in the ambulance, as well as IP standard precautions. Then we shall also discuss transmission precautions during ambulance disinfection. With us online, we have our Commissioner, EMS Services, Ministry of Health, Dr. JB. At this moment, I invite him to introduce himself and give us opening remarks. Welcome, Dr. JB. Dr. JB, you're welcome to introduce yourself and give us opening remarks, please. So as we wait for Dr. JB to give us opening remarks, we are going to have a pre-test which will be displayed soon. I invite our online participants to please do the pre-test as we wait for our Commissioner, Emergency Services, Ministry of Health, to give us opening remarks.
Is this one?
The pre-test is being displayed. Please let's answer those questions very fast so that we can get started. Meanwhile, we await opening remarks from our Commissioner, EMS Services, Ministry of Health, Dr. JB. You're very welcome.
Hello. Thank you. This is Dr. John Baptist Wanyaye, Commissioner for Emergency Medical Services. I just want to take this opportunity to thank you as a team for organizing this, all the facilitators, the Global Health for always being there for us to fund this process. The topic of discussion is very critical to us because, as you all recall, it is EMS during the last response in Kansanda and Mubende, where we had one of our own getting infected while transporting a patient, and we lost one of our paramedics during that time. So it's very critical that infection prevention and control is observed during the transfer of these patients. And you also note that in this recent episode, our officers were more or less the first people to be in very close contact with this case when they are transporting from Bale. The driver and the paramedic, all these people. And we thank God that so far we don't have anybody who has been infected. But that close proximity when a patient is very sick and is in the patient cabin, the room, the environment is so small and the risks are so high. So it's very critical that the people who are attending to understand the processes very well. So I want to thank you, and I request that all of us become active within this training so that we understand effectively how we can do these transfers in a safe way, because the first thing in the response is our own safety. I want to thank you for all the support which you have been giving. I'll be in and out because I'm joining another meeting chaired by the Director General, again on the same response to epidemic diseases. Thank you. I declare this session open.
Thank you, Dr. JB, our commissioner, for those insights. And because of time, let's get started with a pre-recorded video about ambulance disinfection.
When decontaminating an ambulance after transporting an Ebola patient, follow these meticulous steps to prevent contamination and ensure thorough disinfection. Step 1. Preparation. Gather all necessary logistics and materials for the decontamination process. Disinfectants, scrubs, boots, latex gloves, rubber gloves, hood plus Google, gowns and apron, or overall and apron, or cap plus surgical mask plus surgical gloves. Prepare 4 buckets with the following contents. Bucket 1, soapy water. Bucket 2, clean water. Bucket 3, disinfectant solution, 0.5% chlorine. Bucket 4, clean water. Cover the buckets to prevent contamination. Put them in a shaded area to maintain the potency of the chlorine. Establish a secure perimeter to protect the public and the decontamination team. Perform proper hand hygiene. Do the recommended personal protective equipment PPE according to standard procedures. Step 2. Moving the ambulance. The driver moves the ambulance to the designated disinfection area. The area should be clearly demarcated for safety. Step 3. Initial setup. Open the rear doors of the ambulance to enhance visibility and airflow for the decontamination process. Step 4. Waste removal and initial cleaning. Inspect the ambulance for organic materials such as blood or bodily fluids. Using absorbent paper or cotton cloth, remove any organic material. The hygienist or EMT inside the ambulance carefully removes all contaminated waste and places it into the red waste bag. Transfer all waste and linen to an external red bin for proper disposal. Step 5. Cleaning procedure. Use a cleaning cloth soaked in soapy water from bucket 1. Begin cleaning unidirectional all surfaces inside the ambulance, starting from the innermost section to the outermost. Clean the doors and all surfaces from top to bottom. Clean the ambulance floor with a mop soaked in soapy water from bucket 1. Rinse the surfaces using clean water from bucket 2. Pay special attention to door and window handles. Step 6. Disinfection procedure. Apply disinfectant using a cleaning cloth soaked in the 0.5% chlorine solution from bucket 3. Disinfect door and window handles using a cloth soaked in chlorine solution from bucket 3. Pay special attention to mats and avoid using chlorine on the oxygen cylinder. All the equipment is decontaminated using the 4-bucket system. Cover all surfaces thoroughly, including windows and panels. Allow the disinfectant to sit for at least 10 minutes to ensure effective decontamination. Rinse the surfaces using clean water from bucket 4. Open the ambulance doors to ventilate for 20 to 30 minutes to minimize disinfectant odor.
Okay. So that was the visual display of the disinfection steps in an ambulance after it has transported or transferred a highly infectious patient. So we are going to have a recap of the disinfection steps as viewed on the video, and that will be done by none other than Dr. Nakyeyune Marion. Dr. Marion, you're welcome.
Thank you, Charity, our moderator. Colleagues, I hope the video was quite clear and helpful for you to be able to appreciate the process of disinfection. I'm going to only highlight specific areas that I feel the video may not have touched on, so that we ensure that all our colleagues on board in regards to what we want to put forward by the end of this day and the end of this session. I think the biggest take-home message that I'd like us to have is meticulous. For disinfection, you do not have a chance for a do-over because this is a highly risky procedure and it needs to be continuously observed as such. So the person who does this procedure should at least be very observant, and obviously this information is meant to help us as colleagues in the various facilities to ensure that we select the right persons who are able to do this job very well and ensure that they also do not get themselves infected. So safety is very key, and teamwork is also equally important. So in the steps that have been highlighted, we have an area of preparation, and I think preparation is the most important part of this procedure, because you cannot disinfect without supplies, you cannot disinfect without specific items like gowns, as you've seen, the necessary PPEs, the gloves, the jig, the liquid soap, the water. So all these need to be planned so that they are available prior to the whole process of bringing the ambulance and the patient. So all these are things, people are mentioning issues of volume. I don't know whether you can increase volume on another level. I'm seeing many people. Okay. So I'm going to just repeat a bit. We have key areas that need to be considered, because preparation is everything. You cannot disinfect when or plan when the patient has already arrived. So all these things need to be planned prior to ensure that you do not miss any steps. So the reason we're having this video is to ensure that as teams, regional teams in the ambulance, the emergency departments, as facility managers, we know the different items that are required to have to ensure that this disinfection process is done safely and routinely. So the video, I think, has highlighted a few items. You need to have the PPEs, the gowns, the ambulances that are required, the bins, the bin liners, jig, and so on and so forth. Of course, not withstanding the human resource that would do these procedures, which is also quite key in this particular process. And colleagues, I would like us to be reminded that we have procurement processes that can be utilized to acquire some of these supplies prior. And the reason we are sharing the video is so that we can keep an eye on the things that you may not have and try and get them as soon as possible. And also work with the pharmacy department to requisition for some of these items to have them at hand. Should there be any particular need for disinfection for highly infectious disease transfers. So location is being highlighted in terms of identifying a space, but the standard for disinfection sites should be at the Ebola treatment unit, where possibly we have hygienists that are working with the clinical team that can support ambulance disinfection. But should this not be possible, a team should be selected among the emergency medical providers to be able to provide this service for the ambulance after you've handed over the patient. And that's why we ensure that for those few scenarios where that may not be possible to have disinfection at the ETU, an area is cordoned off, as you've seen, and identified with personnel and all the necessary equipment with water and the rest to ensure that there is the disinfection that is done. We would recommend this for all facilities because we are moving into integration of all diseases within our systems, because we also have response to Mpox, and it's also an infectious disease. And this is a requirement and a standard that we should disinfect our ambulances after every transfer. So who should disinfect? With the assumption here is that we are putting a hygienist, but a hygienist is just a name for someone who cleans the ambulance, but it can be an identified trained EMT who can do it with his colleague, or an identified cleaner who can be trained. And this is very critical because it should not be anybody lying around assuming that they are going to be able to follow the necessary IPC precautions. So the person that is identified must be trained and equipped to be able to provide this service of disinfection. And maybe a point to take home is that we understand that some of ambulances may be very old with the cracks within the beds and so on. Would advise that these are not ambulances that would be used because disinfection will become very complicated. Should there be any waste or any body fluids that go into the cracks in the Macintoshes, in the flow of the ambulance and the like. So it would be preferred to have an ambulance that is, we may not say brand new, but at least which has a uniform surface that can easily be disinfected. Colleagues, where does the waste go? And this is also something that's important for the teams in the fields to prepare and plan for. Because after disinfection, what next? Do you pour them on the normal rubbish bin? This should be planned with the help of the administration of the hospital or the units to ensure that waste is not disposed of poorly at the disinfection areas. And this is key because we do not want to become a cause or a source of an outbreak in our various facilities. My last comment maybe will be on the driver. What happens to the driver? Shouldn't the driver cabin be disinfected? Isn't it a high-risk area? Isn't the driver high risk? So the assumption here is that the driver cabin remains a green area. And the green area means that it does not have any source of infection. So usually, as you've seen in the video, the driver stays inside the vehicle and does not step out. And because of that, all we need for the driver's cabin is just general cleaning and, maintaining a standard, clean zone, so that we do not have a dirty area, because we have said that only we disinfect the patient cabins. So colleagues, these are areas that I thought we needed to highlight. One of my colleagues, I think, will dive into, other discussions and how you mix the 0.5, why 0.5, not 0.1 or 2. And colleagues, thank you. And this is what I thought that would share with us as a recap of our video. I hope it has been beneficial, and we hope to disseminate it for all of us to use in our facilities. Thank you so much.
Thanks, Dr. Marion, for the recap and for those insightful highlights. And the steps have been clearly spelled out, and also the most important highlights about who should clean the ambulance, about how to take care of the driver cabin, and all other things she has talked about. So at this moment, I invite Mr. Andrew Okiror, our EMT coordinator, to take us through the IPC standard precautions and IPC controls in the ambulance. Welcome, Mr. Andrew.
Thank you so much, moderator. As already introduced, and I'm going to be talking basically about the IPC controls and the disinfection process of the ambulance. In my outline is clear? Hope I'm now clear there. Basically, those are the key areas I'm going to talk about, the IPC controls, and then the other precautions. Some of this already knows, just basically highlights and appreciating them in this session. Let's carry on. One of the key controls in our disinfection is the elimination. Here we are targeting those potential aspects that can easily put us into a very tricky situation where any hazard might compromise the disinfection and the cleaning process. We have to take them off and keep off areas safe for us to do the disinfection process. The elimination also includes any person that we feel may not be necessary in this process has to get no bystanders and so on. The only system we're using is the Bade system. These are the only two people that we're allowed to work. Anyone else out of the system has to go next. The other one is one of the controls comes in our new normal when it comes to Ebola response. We do not do the disinfection of the ambulance is not only during Ebola response for us in EMS. We do it even, we have a lot of infectious diseases that can happen and that are always there with us. In EMS, we appreciate that. However, when it comes to Ebola, because of its virulence and its nature, we adjust how we do the disinfection. So we again, like Dr. Marion mentioned in her presentation, that the disinfection of the ambulance has to happen at the isolation unit. So the new normal then changes as well. So we try to reduce and adjust on our processes on how we disinfect this ambulance. So instead of using our normal disinfection process and the ambulance washing bay that we have in our facility, our controls, and our disposal, we then shift it and do use the isolation unit with very much controlled environment to reduce the disinfection. And then the other one again is in terms of these controls, And the key here is we will try to make sure that we limit and try to ensure that we don't give an opportunity for the virus to be missed out during the cleaning processes. So one of the key controls here is to restructure our vessels that we use. For example, we know that we usually use type A, type B ambulance and type C. However, this is where type A then comes in because of the nature of this activity. So we try to restructure our ambulances, all the equipment that we feel are not necessary at this point, taken off. Any ambulances that has cracks and maybe small torn carpets or things like that at any point inside the ambulance are useful. But when it comes to this activity, those ones are not appreciated in this point. So we don't use those ones. Next. The other one also is in terms of this control is, we know that the most potential people at risk is the EMTs, the staff, the administrators, and so on. And then this line is rolled out by the administration. Then in case of any outbreak and Ebola, our administrators in the EMS sub-pillar entirely shoulder this burden as well. So directly responsibility of us, the people responding, the drivers and so on. No. So the administration as well has a key stake in this, ensuring that all the SOPs are there too. People are trained. The deployment is as per those people who are trained for the experience and not anyone else was there. And I'm sure we all heard when Commissioner was introduced, he mentioned of one of our colleagues who unfortunately, we all know that story, that got the virus and the outcomes weren't good. So that is why this is a key, again, like I mentioned, very important control. This protocols have to be followed and adhered to. People have to be supervised and monitored and ensure that we are really performing as per the expected guidelines and protocols. And then lastly, on the controls, this is very obvious and we all know this. Like I mentioned in the past slide, that not anyone else does this job for us. It has to be someone who is well trained, and this person is well trained but also fully geared. So this person has to have proper protection. And also in the slide, how the hygienists were dressed in full PPE and level 4. So the team could have transported the patient, and some people in the team, maybe the driver, could be in a level 1, a level 2 PPE, and is in the green zone and is not in contact with the patient. When it comes to disinfection, this is a very different activity in the response. Whoever is engaged or involved in this activity has to be fully donned in a level 4 PPE. And the last part of my slide, this is something that is over and over. We all know this. The standard precautions are key for every response when it comes to infection prevention and control. When it comes to disinfection of the ambulance, cleaning it, and so on, appreciate all these standard precautions. That is the hand hygiene, respiratory precautions. We have to ensure that we have full PPE. And the mask, kind of masks we're using here is the N95 for respiratory precautions. The waste management really has to be well catered for. In this case, we saw in the video how the team was collecting the wastes, and we saw also in the video, it was really clear for us. Any waste that came out from the cabin of the ambulance was red, with red bin liners. So that whatever is, whether it is a bottle of water that the patient had used at the back of the ambulance, anything that comes out from that ambulance at the back, we really consider it as red, as we saw from the video. And then also, lastly, from the video, we saw it, how we manage the linen, how the environment has to be maintained. And so on. So this marks the end of my presentation. I will allow the next presenter to take on, give a time, and for the plenary session. Thank you.
Thank you, Mr. Andrew, for that session. And we are glad that you've highlighted the most important IPC protocols in ambulance disinfection. And to recap a bit for the online viewers, we had 5 steps. Where we had elimination, substitution, engineering controls, administrative controls, and use of PPEs, which is guided by risk assessment. And also, he talked about standard precautions, which included hand hygiene, respiratory hygiene, use of appropriate PPEs, and he highlighted that the mask to be used in this case is the N95. We also talked about safe waste management and use of proper linen and disinfection procedures and equipment. So, thank you so much, Mr. Andrew, for those highlights. And at this moment, let's welcome Dr. Joel Muhangi, who will take us through transmission precautions during ambulance disinfection. Welcome, Dr. Joel.
Thank you so much, moderator. Thank you to the previous presenters as well. Welcome, colleagues. Yes, so we have come to this point of the session. We're basically reminding ourselves because we have done this before, and like the previous presenter said, it's really to remind us of these very important things that are daily or usually in our work to avoid getting infected. So I'm going to focus on the transmission-based precautions that we should have during this disinfection process. And from the previous presentation, we saw that most of these standard precautions really help us avoid transmission. Because we know that the transmission of this virus is through contact, mostly contact. Can also have heavy droplets that can cause risk. So about all that PPE, first of all, we want to try and eliminate or be away from. That's why we have isolation. It's a type A ambulance. We are moving with this patient that needs our constant monitoring of a short distance. We definitely keep in the green zone and avoid being in close proximity. So using this space and engineering controls can help us a lot, like previously highlighted. And in this process of disinfection, we're definitely going to come in close contact with this red zone. And like the previous presenter had said, you have to be fully donned in level 4 PPE. 2 people, that is a dialysis team, who are going to do a thorough disinfection process. And for avoiding of the transmission, we see that they're using full PPE, that is everything highlighted, the gloves, the coverall, we are seeing eye goggles or face shield, N95 mask. So in case of splashes, in case of all these things, we find that you have protection. Then, yeah. And focusing on the waste, because we realize managing this waste, all the things that are in this patient cabin can be a source of infection. It can be a source of infection, and we have to remain safe from that. So let's focus on that, the waste management principles, and also how we handle the linen, keep ourselves safe from getting infection. So we're talking about segregation. All the waste from the ambulance should be considered highly infectious, and we are using only the red biohazard bags for the infectious waste. Like we saw in the video, there was a red biohazard bag used for picking the contaminants and other waste for the disinfection process, and this was transferred to another red biohazard bag with the body outside. We took it to a red waste bin that is designated for particularly that waste. And like we had said earlier, whoever's cabin is considered green, and it's considered a green zone, so there's no risk waste, but all the waste we generate from an ambulance that have handled the highly infectious patient, which are considered highly infectious, and will be categorized as red and disposed of as such. Then you want to immediately place this waste in the designated biohazard containers at the disposal site, and also the waste bag, like we saw, was immediately closed when the body received this waste from the colleague, and you close this bag, you disinfect with 0.5% chlorine before handling this bag, or as you move it to the designated disposal area. Yes, then the waste should be moved safely from the ambulance to the designated holding area. You want to avoid having a lot of it in one bag or overfilling, dragging this. It has to be comfortable for you, and you move slowly without overfilling, without dragging. You don't want to have spills. All these spills pose risk for the hygienists. So you want to avoid all that. You want to have as enough PPE enough PPE and materials to use, as we had seen in the preparation section of this session, to avoid having to overfill or cut corners and use shortcuts as you're handling this waste that is in this area. Then at this disposal area, we advise that the waste should be stored in a controlled space and a well-ventilated area before it is finally disposed of. And also, in case there are containers that you have, they should have proper seal, or they should be properly covered to avoid leaks. Even the bag that we are using to collect this, we should close off, disinfect as we move it to the disposal site. Okay. Now then, linen that is in the ambulance with highly infectious patients should all be treated as highly infectious. So all linen should be treated as highly infectious, and you must be already said that someone will do during the disinfection process, and whatever they're handling or whatever they find in this cabin is considered highly infectious. You don't want to move it a lot, you don't want to shake with linen because you don't want to spread the contaminants and whatever is in the grade highly infectious. Yeah, so let's this will of course will be disposed of in the red area, and the IPC team for the management isolation area or disposal unit will also deal with that in that very way, highly infectious and disposable accordingly. Okay, so that sums up basically what we wanted to talk about today. That is the IPC procedures and protocol we want to keep to or follow during this disinfection process or amniotic contamination process. And just to sum it up, the key action we need to remember: we are treating all this waste and linen as highly infectious, and we are following the strict segregation, collection, and disposal protocols. So we are having all of it measured as red, red waste, and it's collected red bin at the disposal area. Then disinfect these waste bags before you move with them, for example, from the ambulance car. red bin that you're disposing it of at the disinfection area or the disposal place. Then definitely, like we have seen from the second presentation before, all the IPC standard protocols need to be followed strictly, including with the linen, and always prioritize personal protection when handling all this waste and soil linen. So ensure to always remain safe as an individual doing this playing this role. And let me thank you for attending this session. I'm going to hand it over to the moderator to question and answer sessions, the discussions. Thank you so much.
Thank you, Dr. Joel, for those insights. And we've talked about very important precautions, which are very necessary, especially during transfer of an infectious patient. So, and we urge all the EMS providers to take this point seriously, because in most cases, we find these are the first people to be called when there is an infectious patient, and the teams that are involved in transferring these patients from one facility to another. So let us be able to take the key points from, especially about risk management, cleaning, transport, that was talked about. So at this moment, we will come with questions and answers. Dear participants, please feel free to put your questions in the chat, or you can put up a hand, which will be picked, and we are able to answer your questions. So meanwhile, as we are discussing questions and answers, a post-test is going to be displayed very soon. And feel free to answer those questions so that you can be able to assess the knowledge and the skills gained during this session.
We only have one question here, but maybe Jimmy, if you could show us there so that we can address others. Here only displays one question.
So, Ms. Rebecca is asking a question about what type of ambulance should be used during the transfer of the highly infectious patient. So I'll call upon Dr. Marion to answer that question.
Jimmy had shared with you a picture that I would have loved to show the audience some of the ambulances that we have. The National Ambulance Service has two types of ambulances that we actually utilize. That is the type A, rather the type B, and the type C ambulance. The type B ambulance is a basic life support ambulance that usually has equipment that will be required to provide basic life support. Has monitors, suction machines, etc. Very many equipment. So during the response, we want to identify only the equipment that, one, we can easily disinfect, and two, that we are going to use. So usually we have minimal contact, and that's the guidance to prevent infections of the health workers, as well as to encourage ourselves to be able to perform our duties with minimal contact. So we usually prefer to strip the ambulances to what we call a type A ambulance. Now, what is being displayed on the screen is one of the ambulances that you should never use for Ebola or any infectious disease transfer. And the main reason here is because there is no separation between the driver and the patient. I don't know if you can see that. There's a continuation right from the back to the front. And these are, I'm sure, are ambulances that exist within our communities and our facilities. And this is a case in point. It's a type A ambulance, but it does not suit utilization during ambulance transfer for infectious diseases. So it should not be used. But this would be something that looks like a type A. It has minimal equipment. You can leave your oxygen cylinder in, and that is really it that you need, so that you can move the case as quickly as possible to the designated area that the patient is to be moved to. Thank you.
Okay, thanks, Dr. Marion. And I hope, Rebecca, that answer is very clear. And thanks for that question, and we hope it's clear to all the participants. We have another question from Mr. Jude Bergi, who is asking that when does the driver come out of the ambulance after when they are transferring a highly infectious patient? I request Mr. Andrew to take up that question. When does the driver come out of an ambulance after transfer of a highly infectious patient?
Thank you so much for that question. When does the driver come out of the ambulance after transferring the highly infectious patient? We'll also ask a follow-up question from where? Is it from the ETU or at what point? But let me try to answer it. If we have moved a patient to the isolation unit, so the ambulance goes and parks at the offloading area, and this is a red zone. So the driver is seated in the ambulance and the driver is seated in front of the ambulance. And as we all remember, Dr. Joel in his presentation, Julie mentioned that the in front part where the driver is, that's a green zone. Then the back part where the patient is, that's a red zone. So, and the ambulance at this point is parked at the red zone. So the only green zone at that moment in time is where the driver is seated. And so in this case, when the ambulance is being decontaminated, the driver cannot get out. You have to remain in the ambulance, which is after the red zone, being contaminated. Then when the process is done, the ambulance can then drive out. And usually, for those of you that are doing this isolation units, we have ramps where when the ambulance is going to go in the isolation, it drives and it enters through the tires, drives through the disinfectant and goes. So when the ambulance has been seen that it's now getting out, it drives through that disinfectant, gets out, and once out of the unit, then I will say for the driver to get out. Thank you. Dr. Joe, if you maybe ask and wait to add something for that. Otherwise, I hope I've answered that question. Thank you so much.
Yes, you said it right. Thank you, Andrew, for that. There's a separation between the driver cabin and it's fully separate. So the front cabin is entirely separate from the back. And at the isolation preparatory after offloading, we have the disinfection process happening here. And at this point, throughout this point, it's expected that the driver remains in their cabin until the ambulance has gone out of this area and maybe is going to do general washing before waiting for another patient or another dispatch. So during this process, we expect the driver to clearly remain in their cabin until disinfection is complete. Thank you so much.
Okay, thank you, Dr. Joe and Mr. Andrew, for those highlights. We still call upon the participants in case there are any more questions. Please feel free to feed them in the chat, or feel free to put up your hand and we shall select when we ask your question. So at this moment, we are going to display the post test, and we urge all of you to fill in the answers. As we continuously await your questions, and we are ready to answer the questions. So the first test is displayed already. Let's take a few seconds to answer those questions. But still feel free to send any questions in the chat. Let's put up your hand and we shall select you. Well, the first test is being is on our screens. We thank all those who are answering already, and we call upon every participant to attend to those questions so that we can assess ourselves.
Because I think people have still not understood. I thought that after.
Our first test is being displayed and we are almost closing it. And I'm going to request the experts to repeat some of the answers, especially the key areas that were portrayed in the first test. And at this moment, we have the first question, which was which type of adherence should be used during transfer of infectious patient. Yeah, this question was answered by Dr. Marion, and I request her to highlight key points on that question again so that everyone can understand. Welcome, Dr. Marion. Dr. Jimmy, we answered in the red.
Not yet.
We can end it. Okay, so colleagues, for question one, colleagues, the answer was A, type A, because we convert a type B to 1A by removing the excess equipment from it. And I think we displayed the picture of what a type A would look like. The only thing that's important that there should be a separation. So our answer is type A, not B or C.
Okay, thank you, Dr. Marion. And also on the next question, it was about the contact type.
The next question was separation between the patient cabin and the driver.
Yes.
And
so about should there be a separation between the patient and the driver? That one was well answered, but still we want to highlight the right answer to the participants. So I request Mr. Joel to look at that. Dr. Joel, welcome.
Thank you. I see most people got it right. So, and clearly, even in the last presentation, we made it clear that there is definitely a separation between the driver and patient cabin. The ambulance that must be used surely should have this distinction, because one of the cabins is really red and very high risk, and the other is green for that dry event. So I think that is okay for question 2. Thank you.
Okay, thank you, Dr. Joe. Question 3 was how long should we wait after the ambulance is disinfected? And that was asking specifically about the contact time. Still, most people get it right, but still there are a few members that never get it right. And here, I request Mr. Andrew to take up that question to spell it out clearly to our participants.
Thank you so much, moderator, and thank you so much, participants, for participating in this. The answer is, it was even discussed earlier on, it should be really above, not less than 10 minutes for the contact time. And this contact time, we're meaning, or we're referring to the chlorine, those that are going to use for the killing of the virus. So after the wiping with the chlorine, you have to give it about not less than 10 minutes for contact time. That is with chlorine. Before now we come in with the final 4th bucket of the clean water now to wipe off the chlorine. Thank you so much. So the answer was after.
Okay. So the next question was the type of PPE to be used for disinfection after transfer of a highly infectious patient. And here is still, I think it's not yet clear, depending on the answers. And I request Dr. Marion to take us clearly through this. Welcome, Dr. Marion.
Yes, thank you so much, Charity. I wish we could display the types of PPE that I think we may not have something right now, but we shared that those people who are engaged in disinfection are engaged in a highly risky procedure, and they utilize level 4 PPE for the procedure to be done successfully and safely. There is no such thing as level 5 PPE for those who selected 5. Was just to check whether you are aware of the different levels, but maybe as we move forward in our discussions, we shall portray and describe what level 1, level 3, level 4, level 2 PPE looks like, so that it's clear. But level 4 PPE is where we have all the necessary PPEs on the individual, including the face shields, the masks, which are N95, the coveralls, the gumboots, the Macintosh, and the like are the ones that are required, with addition of those gloves that are utilized for washing. So that is the level 4 PPE that is required for disinfection. It's not level 1 or 3. Level 5 does not exist. Thank you.
Thank you, Dr. Marion. So displayed on our screens are the some PPEs.
Just
those are
here, but we shall share, I think, in one of the next sessions, so that it is clear what these levels are. Clarity for everyone.
Right. So thank you, Dr. Marion, for that. So the take home is level 4 PPE. So later the EMS teams be guided on this, especially to guide the cleaners and all other personnel involved in transfer of highly infectious patients. So let us take it that it's level 4, and without that, then somebody should not risk to disinfect the ambulance after transferring the highly infectious patient. Question 5 was question 5. Yes, we had a question when should ambulance surfaces be disinfected? And one answer was right. And that answer was after every transfer of a patient. We should not only wait for only highly infectious patients to disinfect our ambulances, but every patient is considered infectious until proven. So we urge all our EMS team to be highly observant and be able to disinfect our ambulances all the time they transfer the patient. So those were the correct answers to our post-test, and we hope that all our participants have gotten the right information and the right answers and how those answers are right. And as we continue engaging in transferring patients, let us be able to follow those precautions during transfer of patients, but most especially transfer of highly infectious patients, so that we are able to protect the subsequent patients and the health workers and the teams involved in that transfer. So thank you very much, participants, for being present in this session, and we hope most of your questions have been answered. And we are grateful to have had you in this session, which was a very important session, especially in this era when we are faced with highly infectious diseases like Mbarara, like monkeypox, and all others which we may face later. So displayed on our screens is the levels of PPE, and I hope all of you can see them clearly. We have level 1, level 2, level 3, even 4. Yeah, and level 4. So please, let's be able to observe these PPE levels properly. And we take it that level 4 PPE is the one that is supposed to be worn during disinfection of an ambulance, especially after transferring a highly infectious patient. So thank you so much, our online viewers, and I take this opportunity to thank all teams that have participated in this eco session. And at this moment, I request to all our online teams to switch on your videos so that you can be able to take screenshots. And I take this opportunity to thank everybody who has participated in this session. I thank our experts who are here with us for sparing their time to share their knowledge and skills. I thank the Ministry of Health for supporting these sessions, which are very highly educative. And I also thank SEED Global Health for the support and the opportunities that are given for these sessions, because a lot of health workers who are not able to attend physically can be able to get this knowledge and skills through these continued eco sessions. So we are very grateful, and our honored participants, thank you for being part of this. And we hope you've gained knowledge and skills, especially the EMS team and the pre-hospital care teams, about our IPC in ambulances and patient transfers, especially highly infectious patients. Thank you very much. Our session has come to an end.
Our next session.
And our next session is going to be next Friday, and it's going to be about approach to a poisoned patient. It will be next Friday. We still call upon you to be able to organize this session, and the flyer will be shared during the week as we go on. Thank you so much once again, all the teams from all hospitals. Those ones where we can see some individuals and some teams from all hospitals. Thank you so much for logging in, and the hospital care providers. Thank you so much, because this session was mainly concerning you. Thank you so much, and we hope that you put into practice what you've achieved during this session. I wish all of you a nice evening. To have and serve.
You are welcome, madam.
So I request our Commissioner, Minister of Health Services, to close our session. Dr. JB, you're welcome.
Yeah, it was.
Okay, so say this going for meeting. Okay, so. So thank you so much, all of you. I switched on your videos. Our session is closed. Thank you for actively participating in this session. Bye-bye.
Bye.
Okay, bye.
See you.
That's lighting.
That's right. Thank you all for attending. Most of us have you my Friday, as we discussed, I think the presentation.